The chair recognizes the gentleman from Oregon, Mr. Blumenauer, for 5 minutes.
Thank you, Madam Speaker. As we approach healthcare reform, there is no area that is more vital for honest discussion and careful analysis than what happens at a patient's end of life. For most of us, we will get the majority of our lifetime health care in that last year. Indeed, for many, it is just the last few months of life. The most doctor care, the most intervention in terms of medical procedures, the most days in a hospital. This is, by definition, the time of greatest stress, both for the patient and the family, as they watch their loved one enter these last few months and days of life. The evidence is that this is the hardest period to be able to make those critical decisions. We don't want spur-of-the-moment action when we're talking about things that have great consequence for the quality of life for the patient, the ability to extend the quality of life and perhaps deal with recovery. This is also the worst time for people to check out, to have a default option where they just turn it over to whatever the local medical activity may be on that site without a thought and consequence to what the individual wishes of the patient and their family may be. There is strong evidence that in many cases, the very intensive activities, the tubes, the procedures, the operations, the ventilation, the ventilators, actually don't prolong life. And they certainly impact, in a negative sense, the quality of life, the way that the patient may be able to interact with their family and friends in those last few days, and their mindset and their pain level. This research has sparked action from coast to coast. Many states have developed a new end-of-life care directive called Orders for Life-Sustaining Treatment, being developed in over 30 states. They help the seriously ill patient identify their treatment preferences using clear, standardized language. It's written as actionable medical orders signed by a physician, and they help communicate patient preferences regarding the intensity of medical intervention, transfers to hospitals, use of antibiotics, artificially administered nutrition, and resuscitation. Members of my family and I have concluded that we don't want those extraordinary measures as a default and have signed instructions accordingly. What we find, however, is that too many people don't have access to the counseling and activities for them to be able to make an informed decision. The irony is that the Medicare system will spend thousands and thousands of dollars on intensive intervention, intense medical activities, but they won't spend a few dollars to pay a doctor to have a conversation with the patient and the family about what they can expect, what their choices are, and to be able to engage with the patient and the family to decide what they want to have happen. The irony is that we don't do it, I guess, to save money, but the evidence suggests that when people actually have a choice, they choose things that not only improve their quality of life, but actually save money. Individual patients and their families, that choice under Medicare. That's why I have introduced Life-Sustaining Treatment Preference Act, which will provide coverage under Medicare for consultations regarding end-of-life treatment options. It is time for Medicare to be able to address the needs that will truly reflect the preferences, the wishes, the quality of life choices for Medicare patients and their families. It's the humane, compassionate thing to do. It will help us allocate our healthcare resources more appropriately to treat what people want, and it'll relieve the pressure on the healthcare system so that the default isn't always the most intensive, expensive interventions that often, as I mentioned, deteriorate the quality of life in those final days. I would urge my colleagues to look at this option and join me in making sure that we modernize Medicare to meet the needs of patients and their families in their final hours.
Time has expired.
Thank you very much.
The gentleman from California, Mr. Sherman, for 5 minutes.